Good afternoon, Dr. Usmani. This is Dana Holmes. How are you today?
Hey, Dana. How are you?
I'm good, thank you. I just wanted to interject that I, as a smoldering multiple myeloma patient, find that it's a very important message to deliver to patients to seek counsel with a myeloma specialist. And honestly, if you have the precursor diseases, don't wait until you find yourself in the myeloma world. Try to get to a specialist before and develop that rapport and that relationship. Because I really, really do think that that's critical for a smoldering patient for a lot of reasons, to get the right diagnosis, to get the right evaluation, and the proper monitoring during that smoldering time. So I appreciate you encouraging patients to do that as well. I have a question for you about Darzalex. I created a Facebook group, actually, for Darzalex patients, not only anybody who's using it, but anybody who's interested in it. And we've had a lot of interesting discussions and conversations and information sharing. It's really been very, very helpful for patients, and especially new ones that are heading into the infusions. And some of these discussions are also uncovering that people are already getting it in different under different situations that are probably off-label at this point. So it's curious to me to see that already happening. And I realize that from a clinical standpoint, people do need this drug, but I think from a data standpoint that you tend to lose some of the the data when this happens. So it's a that double-sided coin. And I wanted to find out from you your thoughts about using Darzalex after a stem cell transplant, like in a maintenance setting.
I think there's music in the background.
Sorry, that's my phone.
Not a problem, Gary. I don't think that's a good idea. Personally, especially in absence of data, I don't think that is a very good idea to utilize daratumumab in the maintenance setting. And it's not that we won't see any clinical activity, but it's again the principle that you need to have some data to support what you're doing. And if you don't go picking therapies for patients in settings where it hasn't been really examined, because you won't know how to gauge the outcome. So the maintenance setting in a post-transplant situation, I'm not so sure. I mean, it's a good question to ask in a clinical trial, but to do it off-label, it is going to be fiscally difficult, and especially in absence of data, perhaps not the right decision.
Good. I'm thankful that you mentioned that and clarified that, because I think it's an important message to send out to folks. But again, I don't know if it'll do anything, but just as long as people are aware of that. I have a member in my smoldering group who transitioned to multiple myeloma, and she had her stem cell transplant with Dr. Harry, and he's developed a trial, or someone did, whatever it is. There was a trial that he's now introducing a checkpoint inhibitor after the stem cell transplant. So he's actually capturing that important data to be able to share amongst the community. So that's really just so critical, I think, as a patient also to do it the right way. Dr. Usmani, what is your thought about 2 weeks ago, Janssen announced that they're going to be combining daratumumab with a checkpoint inhibitor, something called, and boy, is this a mouthful, atezolizumab. It's basically a checkpoint inhibitor. It's an anti-PD-L1, and they're combining that in a study, and it's a phase 1. What are your thoughts about combining a monoclonal antibody and a checkpoint inhibitor?
I think that is we've talked to Janssen and several drug companies who have checkpoint inhibitors, about that possibility, and I'm really excited about that clinical trial. I can also tell you that there are other clinical trials with similar concepts that will be coming down the pike. So this is not the only checkpoint inhibitor plus anti-CD38 monoclonal antibody clinical trial that is going to be run. There are others coming down the road as well, and the concept is really exciting, and I'm looking forward to it.
Do you see it moving into the smoldering patient population for clinical trials? Because that's honestly, that's like my dream cocktail at this point.
That is quite possible, but it may not happen until either later this year or early next year.
Well, I'll hold on to my smoldering shoe until then, Dr. Usmani, and when you open that trial, know that I'll be at your doorstep. Good. Listen, thank you so very much for your time. You're always so receptive, and it's just so incredibly great for patients to be able to communicate directly with myeloma specialists such as yourself, and I appreciate what you do for the myeloma community.
You're welcome.
Thank you, Dana. Dr. Usmani, we just like almost 10 minutes over time. I'll just ask you one more question, which has been sent in and we can wrap up. Question is, how is the scientific community tackling the increased adverse events burden, which is a part and parcel of combination therapies?
We're trying to develop therapies that have less adverse events. That I've tried to highlight the advantage with monoclonal antibodies and their safety profile. The fact that ixazomib being an oral agent appears to have less neurologic side effects than bortezomib. So it is an advance from a safety standpoint. The main idea is develop therapies that have less of an adverse event burden, and B, identify those adverse events early so that you can dose reduce and mitigate the side effects. I think those are the two key elements that we have to work on.
Thank you, Doctor. Thank you, Doctor, for extra time too. I think it is amazing discussion, great learning, and great listening to. Gary, Jack, and Cindy, as always, thank you for your support. And today's talk, the listeners will be made available on CureTalk's website along with its transcript. You can visit curetalks.com for details of upcoming talks. And thanks a lot. Have a good day.
You're welcome.
Thank you. Thank you, Doctor.
Thank you, Priya, Gary, Cindy, and Jack.